Hello and welcome to yet another episode of Dr. Sin. This is me, Naina, with you. Today we have Dr. George Varghese, who is a well-known oral and maxillofacial surgeon. Let us welcome him to the show. Hello, doctor.
Hello,
Before going further to the topic, we would like to know more about you.
I'm Dr. George Varghese, now currently working as the principal and professor of oral and maxillofacial surgery in Government Dental College, Kottayam.
Doctor, what is oral and maxillofacial surgery?
There's a surgical specialty that deals with the management of diseases and conditions affecting our mouth, jaws, and face. So, those conditions and diseases can be either developmental, that will be at the time of the birth of the child, it will be there, or it can be later develop. For example, patient can have a trauma to the face, or it can be an infection that is affecting the mouth or the face, or it can be a cancer or a tumor that is affecting the jaw, mouth, or the face. And the specialty of oral and maxillofacial surgery had a very humble beginning, to say, years back, when it dealt with the diseases in the mouth alone. For example, the simplest one was at that time was removal of the impacted teeth or unerected teeth. But later on, as the science advanced, especially the science of the anesthesia, where now we have reached at a point where we can do a major surgical procedures taking hours. Originally, the procedures that was done was only under local anesthesia, and the procedures were limited. And now the more extensive procedures we do concerning the face and the jaw. The anesthesia development, along with the other specialties like the development of the other surgical specialties like general surgery, plastic surgery, and has also contributed a lot for the development of this specialty. And the introduction of the biomaterials, for example, for the cosmetic surgery of face, we introduce a lot of biomaterials, implantable, which are accepted by the body. And along with that, the development of the asepsis, that is sterilization procedures, and the other innovative procedures are contributed a lot to what the specialty has reached now. Now the specialty has gone into such an extent that we correct not only the face and jaw, even up to the skull-based surgery. There are maxillofacial surgeons who does skull-based surgery, and even to the neck, conditions affecting the neck. So now we used to say that everything under the purview that's beneath the brain and above the lungs, that is beneath the dura mater is the lining covering the brain, and the pleura, that is the lining covering the lung. So we have such a wide area where we actually do surgical procedure.
Okay. Doctor, how it differs from other dental specialties?
Naina, it's a very good question, because very often people consider the maxillofacial surgeons along with the dental specialists alone. We are actually dental surgeons who spurted out or who have grown from our specialty to become a maxillofacial surgeon. For example, there are a lot of other specialties which you might have heard, like the orthodontist or the endodontist who treat the root canal, or the prosthodontist who replace a missing tooth, or periodontist who treats the gum. But all the other dental specialists, they can have or limit their treatment procedures to a dental clinic. But maxillofacial surgery is not like that. If you want to be a successful maxillofacial surgeon, and if you really need to involve all the wide variety of cases that you come across, you need a well-equipped hospital. Then only we will be able to subject the patient to procedures, major surgical procedures under general anesthesia, admit the patient after that, take care, that is have the patient in the intensive care unit, all those things. And you cannot do that in a simple dental clinic. So even the training is also so advanced for the maxillofacial surgeons that we are equipped, or not equipped, we are trained to do the procedures. So for example, in most of the institutions, for example, I am in a teaching institution at dental college. So we have an associated medical college where we have a well-equipped theatre, ward, and then casualty, where we give or manage the patients.
Doctor, what is the trainings for maxillofacial surgery?
See, basically, before you go for maxillary surgery, you have to complete, in India, you have to complete your basic dental training, that is Bachelor of Dental Surgery, that is BDS course. Following that, you completes the internship for 1 year, then you go for the maxillary surgery. Maxillary surgery, the training is actually for 3 years. And the first year, the student undergoes training in the basic medical subjects, and some of the universities you have to appear for an examination after the first year. Basic medical subjects in the sense that anatomy, physiology, biochemistry, pharmacology, pathology, microbiology. Okay. So this has to be studied properly, and then you go to the second year. And the second year you will be posted in the other associated dental specialties. In the second year, the students will be posted in other associated medical specialties because they have to have the basic background training in these specialties if you want to be a good maxillary surgeon. The associated medical specialties, I mean to say plastic surgery, then anesthesiology, ENT, ophthalmology, neurosurgery, general surgery. So the training in these specialties will help the budding maxillary surgeon to manage complicated cases. In the second year of the course of study, the students will be posted in other associated medical specialties to equip the students to manage more difficult and complicated cases. For example, they will be posted in specialties like plastic surgery, ENT, ophthalmology, neurosurgery, anesthesiology, and even general surgery. So they will get adequate training in these specialties because some of the cases we do combinedly. And as I have mentioned earlier, that maxillary surgery is not a table tennis play, it's rather a football where there are team effort and team spirit has to be there. And unlike other dental specialties like orthodontics or periodontics or prosthodontics, we are actually dealing with the more critical situations, especially when we manage trauma victims or patients who need surgical treatment of oral cancer.
Doctor, you told that you manage trauma cases too. What are the main causes of trauma?
The main cause of trauma in our part of the country is road traffic accidents. Even with the introduction of stringent laws to govern the traffic rules or traffic accidents, still the trauma is on the rise. Another reason for trauma cases or patients reporting with trauma is fall from height, or sometimes it can be industrial accidents. Then traveling by bicycle or sports, all this results in trauma.
Doctor, how do you treat trauma cases?
So that's a very good question because simple trauma cases in which there is only a soft tissue involvement, or when there is only a injury to the tooth, or sometimes there is only a fracture of the mandible, it can be managed by the maxillofacial surgeons alone. Because there are other trauma cases, complicated cases when other parts of the body are also injured. For example, a case of a trauma, facial-maxillary trauma with the associated head injury, or a facial-maxillary trauma with the associated injury of the chest or the abdomen. We know that the maxillofacial region or the face is very in close proximity to the important structures like the nose, the eye, the brain, and the ear. So, in such cases, what we need is a multidisciplinary approach where all the specialists have to be involved. So, that's the reason why I told you that the maxillofacial surgery training, the students will be posted in the different medical specialties, so they will get an in-depth knowledge of the procedures that they are doing. So, trauma, when you talk about severe trauma cases, not like a tooth loss or a simple fracture of the lower jaw or the mandible, but when we speak about trauma victims where there is a more advanced, more severe injury like that we come across in a major traffic accident, we need the patient has to be stabilized first, that what we call the primary care. So, such time at that time our attention is more given or directed to the survival of the patient or the resuscitation of the patient, that is the actual time. So, we treat the patient to save the life first. For example, the patient may be having a blocked airway, so that to be cleared either by our any instruments, or some days we may have to put a artificial hole into the throat, or what we call the tracheostomy. And our next attention will be, or area of interest will be to stop the bleeding from the major vessels that occur after the trauma, or look into the where there has been a major head injury. So all the, and or where the patient can breathe as such, or there is an injury to the abdomen, or that's the associated structures like the liver, spleen, or there is an injury to the chest, or with an injury to the lung, where the patient may again have sometimes pneumothorax. So all this primary care or the emergency care will be directed for the saving the life of the patient. So once the life of the patient is addressed, because it is what we call is the golden hour, because it is the first 1 hour after trauma that we can attend to the patient properly, and if we can bring about a resuscitation of the patient during that golden hour, immediately after trauma, our attention is mainly directed at saving the life of the patient. That's more important, because there is no point in having a beautiful face without a life inside. So what we do is that we try to resuscitate the patient. And as I mentioned before, that all the associated or the relevant specialists are also consulted to make sure that there is no head injury, or there is no thoracic injury, or the abdominal injury. So once we feel that everything is settled, so for example the patient can breathe, or sometimes the patient may be unconscious because head injury may be there. If the patient can breathe, or there is adequate ventilation, then we go to control the bleeding. So that also we control and stabilize the patient to such a extent that we can operate on this. So this stabilization is very important in the first 1 hour, what we call the golden hour. So if the patient is not getting the proper medical attention, of course the role of the maxillary surgeons as well as the other medical specialists, if the patient is not getting proper medical attention during that 1 hour, the life of the patient can be jeopardized. So we make sure that the patient is alive, the patient is breathing, and the patient is well stabilized. Then the role of the next step is the further role of the maxillofacials that is coming. So at the earliest, we will take the patient to the theatre to fix any fractures that has occurred in the lower jaw or the upper jaw or face, or other injuries, associated injuries, when sometimes the other specialists like the orthopedic surgeon, they also will come to fix the fractures of the long bone. So earlier what we do is that when the maxillary surgery was a little primitive, maybe after, or maybe back 30 years back, what we do is that the upper and lower jaw were used to be fixed together. So that means the patient cannot have a solid diet, he will have to survive on a liquid diet. Now the times have changed, we have new implants, new biomaterials, new metals that can be placed within the jawbone. So what we do is that we have mini plate and screws that for fixing the fractures of the upper and lower jaw. And another development is that the introduction of the biocompatible plates and the bioresorbable plates. Because if you put a metallic plate like a stainless steel or a titanium inside, that has to be removed later. For example, if it is a growing child, and the presence of the plate inside the jawbone of a growing child will interfere with the further growth. So such cases we have to remove the plate. And some adults also ask, they don't want some metal inside, some hardware inside the jaw, so they will request for a removal. So what we do now is that current trend is we will place a bioresorbable plate. So that plate has the advantage that in the course of time that will be absorbed. We don't have to we don't have to remove the plate at a later stage. And the advantage of using this plate and screw is that from the next day onwards the patient can have a normal diet, and his job is also not interfered. He can go have the normal job, or he can go to school maybe after 3-4 days. On the other hand, previously what we used to do, that we used to fix the upper and lower jaw together, so the patient cannot open them up, neither can he speak, and neither he can have a normal diet. And there were instances where has been some weight loss also, because you can just imagine how one survives on a liquid diet, naturally his weight will be lost. And more important is that his job or is interfere, or is if it's professional, that days of leave he has to take. Now he can return his normal life after having to stay in the hospital for 3-4 days. So that's one of the main advantages of the, or one of the recent developments in the trauma management.
Doctor, in which age group is trauma common?
You might be remembering that you have asked about the causes of trauma, isn't it? See, that's also have a direct bearing regarding the age of the victim. For example, road traffic accidents, now the youngsters are using the fast bikes and racing cars. So, trauma following road traffic accident is one of the most common thing. And it is usually the youngsters they are involved, especially from the age group of 17 or maybe up to around 50 or 60. But there are instances when there is a bus or a van collides with something else, or when multiple travelers are there in the bus, naturally it can affect the various age group. But if you consider a single accident in which the trauma victim is affected, it usually comes in the younger age group, somewhere between 17 and 40. And the most disastrous aspect is that those people will be the only breadwinners in the family. So the whole income of the family is lost, and they are having, and the management is also, the recuperating time is more, and the expense involved is more. So that will shatter the total income of the family.
Okay. Doctor, the same way you have talked about oral cancer in between. Can you talk more about it?
Yeah. Oral cancer is one of the disastrous diseases affecting our part of country, especially the Southeast Asia and India. And even some say that one of the highest incidence of cancer occurring in the body is oral cancer in our part. And various reasons has been attributed to this. Especially it is more common in the males actually, and males after 17, and it goes up to the middle age. And several reasons has been attributed to it. For example, one of the commonest reason is use of tobacco. As per not the type of tobacco that was used in the past was the panjwig, in which they used the betel leaf, the aracanite, the slaket lime, and the tobacco such. Now the new generation of the pan has come, that is the pan masala, gutka, like that. So that is actually creating devastating effect in the younger generation. So the use of tobacco, either in the traditional method or the newer version, is one of the main reasons. Second is the improper oral hygiene. Patients, those who doesn't care about the mouth, the chance is comparatively high. And some patients may be having a sharp teeth or a denture that is continuously pricking or injuring the tongue or the cheek. That also is another reason. Then some patients may be have a poor nutrition. Those who are in the low socioeconomic status, their nutrition may not be adequate. They don't be having an adequate intake of the carbohydrate, protein, fat, minerals and vitamins. So the deficiency of these again attribute to the occurrence of oral cancer. Then yet another is the precancerous conditions that are very important in our region, because that also acts as a prelude or a precondition for the development of oral cancer. And these are conditions which can be diagnosed easily and at the same time managed also, precancerous. For example, some of the precancer conditions that we see now in our part of the country is leukoplakia. Leukoplakia is actually a white patch inside the mouth, which is usually common in smokers. And the peculiarity of the white patch is that it cannot be scraped off easily. And another is submucous fibrosis, in which the patient will not be able to open the mouth much, and the mucosa of the lining of the mouth is very much thinned out, and the patient will not be able to chew food, open the mouth properly, and they will not be able to tolerate hot and spicy foods. They will not be able to, and even some may have difficulty in swallowing. So it has been found that the submucous fibrosis is very commonly associated with pan chewers as well as those who use the pan masala or pan parag or gutka. So if you can, all of the 3-5 conditions are there, and if these are, you can avoid these habits, or you maintain a good oral hygiene, this can be avoided. And the management of oral cancer, when you consider the management of the oral cancer, the maxillary surgeons have a definite role, because the patients will be coming with some disease or discomfort in the mouth, usually to the dentist or the maxillofacial surgeon. And the first thing what we do is that we do a proper clinical examination. And the oral cancer can appear either as an ulcer sometimes, where there is a break in the continuity of the tissues, or it can be a growth, or sometimes it can be a bleeding from the gum, or it can be a sort of a cauliflower like growth inside the mouth, or it can be a nodule. And once it is not treated properly, the oral cancer usually will spread to the regional lymph nodes. That is the, you know that there are glands in the beneath our lower jaw or in the neck. So that will be spreading to that we call secondaries. So once the oral cancer is diagnosed at the early stage, it is easy, but easy to manage. But once it spreads to the neck, management becomes difficult. And one of the common method of diagnosis, as I mentioned, it is clinical examination. Examine the patient properly. Then another method is you take a cytology, or take a smear by scraping that surface tissue and studying it under the microscope. But the accurate method is taking a biopsy. What you do is that we are using a knife under local anesthesia that we can do with the minimum setting. You don't have to admit it in a hospital. Using under local anesthesia, you take a bit of the tissue from the growth, and you process it and study it in the microscope, and that makes the correct diagnosis. And the oral cancer is what you call, you can say that it is it's a common term. There are different types of cancers that can occur in the oral cavity. It can be, the usual type is the epidermoid carcinoma, that is originates from the tissues of the mouth, or sometimes it can originate from the bone also, the mandible or lower jaw. Then it can be considered as a sarcoma. And I mentioned that usual oral cancer can spread into the lymph nodes, the nodules beneath your lower jaw or the neck. But the sarcomas, they spread by blood, through bloodstream they spread. So it have a the extent of metastasis is much more. It can spread to the lungs or liver, and such cases the management becomes more difficult. And if you think of the management of oral cancer, the usual oral cancer, there are 3 modalities usually. First one is the surgery, second one is the radiation, and third is the chemotherapy. And the best method usually, if it is a small one, if it is a treatable one, even large extent also we can treat. But the best method we can consider it is surgery, because I am talking from the point of view of a maxillary surgeon. Because the radiologists who treat by radiotherapy, they might say that radiation may be better. So our consensus among the maxillary surgeons is that first you diagnose oral cancer, you treat it by surgery. Of course, there will be adjuvant radiotherapy which you will give, that is supporting radiotherapy, which you can give either before the surgery or after the surgery. So that is surgery, radiation, and the chemotherapy. Chemotherapy is an injection of chemotherapeutic agents. But that's not very common when you think of treatment of the oral cancer. And one advancement when we think of management of oral cancer by surgery is that now we have good surgical methods to reconstruct the lost part. Because suppose the oral cancer is affecting the cheek or some part of the mandible, you may have to remove that area. So the patient will be having a huge defect. So sometime back, maybe years back, we used to reconstruct it with local flaps, that are tissues that are taken from the adjacent area, either from the neck or from the chest. But disadvantage of such flaps is that when you are removing a lower jaw, there is no mandible inside, no lower jaw or bone inside. So that makes the defect is still there, the patient will not be able to chew properly. Now the science has advanced that we can even reconstruct that bone with viable bone, that is not just a bone removed from some other part of the body, but a bone that is having a viability with a blood vessel and sometimes with a skin paddle and muscle. So what we do is that we either we take from usually the leg, that is a fibular graft, that is a part of the bone that is taken from the lower leg, and with a blood vessel associated, and we take it to the lower jaw and anastomosis that is, and connect it to the adjacent vessels like the blood artery and the vein. So the advantage is that the patient will be having a viable bone and it will be taken up. But the difficult part is that you need extensive training, because the anastomosis, that the connection between the recipient and the host. Recipient is what we bring here, what bring here, and the host, that area where it is accepting. So that graft, so that has to be anastomosed with a microsurgical method. We need a microsurgery. So that you need training. But the advantage is that if it is properly done, it will be completely taken up. And what we do is that there are centers, in our center also we do. Once the distant bone is accepted here, we even put implants there. That previously there was no scope for implant braces, but since the bone is viable, we can put a implant there and the patient have a normal function, even chewing also after some time.
Thank you, doctor, for spending a valuable time with us. So that was Dr. George Varghese with us. Until we see next time, this is me, Naina, signing off.